The following podcast is part of a certified educational activity titled Assessing the Potential Role of Emerging Therapies in the Early Diagnosis and Optimal Management of Chronic Visceral Acid Sphingomyelinase Deficiency. Access the entire activity and complete the post-test at peerview.com/NPH860. Downloadable slides and practice aids are also available.
Welcome. Thank you very much for joining us today. My name is Robin Lackman. I'm a consultant in metabolic medicine at University College London Hospitals, and I look after adults with inherited metabolic disease. I'm joined by my colleague Melissa Wasserstein. She's the chief of the Division of Pediatric Genetic Medicine at Montefiore, and she looks after children with inherited metabolic disease. And today we're going to talk to you about one specific inherited metabolic disease, the lysosomal storage disorder acid sphingomyelinase deficiency. We're going to talk a bit about its history. We'll then go on to talk about its clinical presentation, how you diagnose patients and how you manage them, both how we manage them in the past and presently, and how that management might change in the light of results that are emerging from clinical trials of a novel enzyme replacement therapy for this condition. So I'm going to start with a brief historical timeline. So Alfred Niemann and Ludwig Pick were early 20th century German physicians who first described this condition. They described children who presented with distended abdomens and organomegaly and with a neurodegenerative disease that was different from that we saw in Gaucher disease. And these patients continued to be described in the years to come. And then in the late 1950s, Alan Crocker and Sidney Farber published the definitive description of the disease. And this was the sort of paper you simply can't get published anymore, 100 pages of detailed clinical and biochemical characterization of these patients. They described a condition that was genetic, was autosomally recessively inherited, that affected young children with early progressive central nervous system involvement, with enlargement of the liver and the spleen, and with storage of sphingomyelin in organs and in these foam cells that infiltrated the liver and the spleen and the bone marrow. And this was the classical infantile onset form, what they called Niemann-Pick disease type A. But they also recognized that there were other clinical presentations of this disease. So as we see with other lysosomal storage disorders, as well as this classic infantile presentation, there are also patients who presented later on in life, in childhood and even in adulthood, who had slightly different disease severity. In the infantile patients with the most severe form of the disease, as well as the organomegaly, they had this progressive neurodegeneration, the neuronopathic form of the disease. But patients who presented later on in life still had the organomegaly, the liver and spleen involvement, but didn't have the neurological involvement and went on to develop other features, lung involvement, for instance, that hadn't been so readily recognized in the younger patients. And so we now have two different presentations, the infantile type A, the juvenile and later onset type B disease, both of which are the two ends of the spectrum of Niemann-Pick disease, or acid sphingomyelinase deficiency as we call it now. Then in 1966, Roscoe Brady and colleagues were able to identify the enzyme that was deficient in Niemann-Pick disease. And they found out that Niemann-Pick disease was due to deficiency of the enzyme sphingomyelinase. And that put it as a member of the sphingolipid lysosomal storage disorders, a group of diseases we can see here that, as well as Niemann-Pick disease, includes Gaucher disease, but also other visceral diseases, Fabry disease, and diseases of the neurological system, the gangliosidosis and the metabolic leukodystrophies, metachromatic leukodystrophy, and Krabbe disease. And you can see that, as well as being clinically closely related, Niemann-Pick disease and Gaucher disease are biochemically closely related. And therefore, when you're diagnosing these patients who present with organomegaly, and if they're infants with a progressive neurodegenerative disease, it's important to check both of these enzymes, both the sphingomyelinase level and the beta-glucurocerebrosidase level, because those are going to be your two main differentials of a lysosomal storage disease as a cause of these conditions. In 1991, Ed Schuckman and colleagues were able to clone the sphingomyelinase gene, and this opened the way up both to molecular genetic diagnosis and eventually to treatment, because it was now possible to clone the gene, having cloned the gene to make the enzyme, and to consider things like enzyme replacement therapy, which we'll come on to later. And so we have a disease, a Niemann-Pick disease, acid Sphingomyelinase deficiency, which is rare. We know now we can do genetic studies that the overall prevalence is about 1 in 250,000. That the later onset form, Niemann-Pick disease type B, is commoner than the infantile onset form. But there are certain populations, the Ashkenazi Jewish population, for instance, where founder effects mean that you actually have much higher frequency. And the frequency of the neuronopathic form of Niemann-Pick disease type A, is actually about 1 in 40,000 in the Ashkenazi Jewish population. So much, much commoner than in the general population. So after that brief introduction, I'm now going to hand over to Melissa Wasserstein, who's going to take you through in more detail some of the clinical features of acid Sphingomyelinase deficiency and how you go about diagnosing it in your patients. Melissa.
Hello, my name is Dr. Melissa Wasserstein. I'm a pediatric geneticist and professor of pediatrics and genetics at the Children's Hospital of Montefiore and the Albert Einstein College of Medicine in the Bronx in New York. So when we're considering how to diagnose ASMD, there are a few key considerations. First, we need to think about the clinical manifestations of the ASMD subtypes, the differential diagnosis of ASMD with other disorders, and then we're going to talk about consensus recommendations to help make the diagnosis of ASMD. The biochemical defect in acid Sphingomyelinase deficiency results from an abnormality in the enzyme activity of acid Sphingomyelinase, as it normally breaks down sphingomyelin into ceramide and phosphocholine, resulting in an accumulation of sphingomyelin. There is a spectrum of clinical severity for ASMD deficiency, ranging from the severe phenotype to a more attenuated or milder phenotype. Children with a severe phenotype, which is also called infantile neurovisceral ASMD or Niemann-Pick A, have an onset of disease in early infancy. They have rapidly progressive, severe visceral disease and rapid neurodegeneration, usually resulting in death by approximately age 3. On the other end of the spectrum is chronic visceral ASMD or Niemann-Pick B. That onset is typically anywhere between infancy to adulthood, and the phenotype ranges from a slowly visceral, variably progressive disease with little to no neurologic involvement, and death can occur anywhere from childhood to late adulthood. And in the middle is the chronic neurovisceral ASMD or intermediate Niemann-Pick disease, which has an onset that ranges between the infantile neurovisceral and the chronic visceral form, and a phenotype that similarly ranges between that of the severe infantile form and the chronic visceral form. There tends to be some visceral involvement, and there tends to be some neurologic involvement, and death usually occurs anywhere between childhood to mid-adulthood. This is a representation of the clinical spectrum of ASMD. The infant on the left side of the screen has Niemann-Pick A, or acute infantile neurovisceral ASMD. And the two individuals in the middle and on the right both have the chronic visceral form, or Niemann-Pick B. And you can see that spectrum of severity, with one having milder disease, the adult, and one having more severe disease, the child in the middle. The clinical manifestations of chronic visceral ASMD result from the accumulation of sphingomyelin in the cells of the liver, spleen, lungs, and bone marrow. As I said before, it's non-neuronopathic, it is pan-ethnic, and there's a very variable clinical presentation. Most people who have Niemann-Pick B have some element of pulmonary disease, some element of cardiovascular disease, particularly dyslipidemia. Most have liver disease, and most have splenomegaly, as you can see on the picture on the right. Most people have some degree of skeletal disease, hematologic disease, and children tend to have pediatric growth restriction. Because of that, of the broad clinical manifestations, it is challenging to diagnose patients with ASMD. Importantly, early intervention for all forms of ASMD is essential to manage the secondary complications and optimize the patient quality of life. Most practitioners outside of specialists are unfamiliar with the signs and symptoms of ASMD, which shares a number of overlapping clinical features with other lysosomal storage disorders, other metabolic diseases, and endocrine or hematologic disorders. Patients with ASMD present a diagnostic challenge that often results in considerable diagnostic delay, particularly for patients with chronic visceral disease or Niemann-Pick-B and the chronic neurovisceral form or the variant Niemann-Pick-AB. An algorithm for the diagnosis of patients with ASMD was developed in order to provide an educational resource on the current practices for the diagnosis of ASMD. Although the care of patients with ASMD is typically provided by metabolic specialists or medical geneticists, guidelines that we've created are directed at primary care practitioners like pediatricians and internists, as well as specialists like pulmonologists, hepatologists, and hematologists. So they are able to recognize these patients in order to provide the appropriate care and referrals. So by system, I'm going to run through some of the morbidities that we tend to see in patients with ASMD. So first, focusing on the liver. Liver morbidities are a significant phenotype of ASMD. Most people have hepatomegaly, and the mean liver volume is 1.91 multiples of normal. And the range that we have discovered is about 0.93 up to almost 3 times normal. Many patients have non-cirrhotic fibrosis. Many have cirrhosis. Most people do have transaminitis, and liver failure and liver transplant have been noted in multiple people with ASMD. You can see on the right, there are some pictures from liver biopsies that were taken from a study with ASMD patients. And we found that most patients in this study actually did have fibrosis, even when it was unexpected, and they didn't have any other clinical evidence of liver failure. Splenomegaly is also a very important and impactful phenotype of ASMD. The mean spleen volume in a series of patients was almost 13 times normal, ranging from 4.5 to 27 times normal. Hypersplenism and all of the downstream manifestations of hypersplenism are a significant part of morbidity in ASMD. An extremely large spleen can cause early satiety. We've had patients who've had splenic vein tears, splenic rupture, and a chronic pain because of the splenomegaly. Putting those together, let's again review the differential diagnosis of somebody who has hepatosplenomegaly. Of course, it can be a manifestation of certain forms of malignancy. It can be a manifestation of primary liver disease with secondary splenomegaly, as well as other lysosomal storage disorders. Importantly, Gaucher disease, which is a fairly common lysosomal storage disorder, also presents with hepatosplenomegaly, as can Niemann-Pick type C and lysosomal acid lipase deficiency. Dyslipidemia is also an important phenotype in ASMD. Particularly, the cardiovascular disease includes valvular heart disease, which sometimes can be clinically significant, and it appears to correlate with more systemic disease. And the valvular heart disease tends to occur because of deposition of sphingomyelin on the leaflets of the valves. Most people with ASMD have an atherogenic lipid profile. There is an elevated LDL, elevated triglycerides, and most people do have a very low HDL, which in my opinion does seem to correlate with the overall degree of severity. Many people also have coronary artery calcifications, which we measured because of the dyslipidemia, and to the point where we do recommend that coronary artery calcification scores get done every 2 to 4 years. And they're a good way, a very non-invasive way to measure the degree of coronary artery calcification just using a CT scan. Some patients do end up having heart failure because of this combination or isolated forms of valvular heart disease, as well as the cardiovascular dyslipidemia profile. On the right side of the screen, you see an atherosclerotic coronary artery disease taken from a CT scan of a woman 19 years old with Niemann-Pick-B. And you can see that little white arrow, which is pointing to a calcification at the left anterior descending artery, which would be highly atypical in somebody of her age without heart disease. And on the bottom of the screen, you can see a typical lipid profile in somebody with ASMD, where there's an elevated total cholesterol, an elevated LDL cholesterol, and a low HDL cholesterol, as well as elevated triglycerides. So for the differential diagnosis of somebody with dyslipidemia, as we know, dyslipidemia is quite common. In terms of lysosomal storage disorders, lysosomal acid lipase deficiency clearly can cause a dyslipidemic profile. Some patients with Gaucher also have a low HDL cholesterol. Clearly, primary dyslipidemias as well as secondary dyslipidemias are common in the general population. Pulmonary manifestations, again, are a very significant component of ASMD. Most patients have some degree of interstitial lung disease. Many suffer from recurrent respiratory infections. Some become oxygen dependent over time, and those who eventually become oxygen dependent tend to be those with more severe disease. In a series of 103 patients, actually, those who eventually did require oxygen during the course of the study, and it was a small number, all died during the course of the study, indicating that they had more severe disease. Pulmonary hypertension has also been noted in patients with ASMD. And you can see this chest x-ray. This is from a child with Niemann-Pick who had actually no pulmonary symptoms, but it's typical to see this degree, which is quite obvious, of interstitial lung disease even in a child without clinically significant disease. So the degree of radiologic abnormalities seems to precede the onset of clinical symptoms. So the differential diagnosis of pulmonary disease includes environmental exposures. It includes infection, acute and chronic infection, things like TB, things like viral pneumonia. Sometimes autoimmune disease can present with an interstitial kind of lung disease pattern, as well as chronic respiratory diseases such as cystic fibrosis. So we have created a diagnostic algorithm for ASMD presenting during infancy and childhood, and then another one for ASMD presenting during adulthood. So I'm going to go through this one carefully first. So if you have somebody who has splenomegaly and hepatomegaly, first you should check for features that are suggestive of ASMD, including cherry red spots, which are common in children with the neuronopathic form of ASMD. Is there developmental delay? Again, typical for chronic neuronopathic ASMD. Is there low tone? And is there a low HDL cholesterol? Those are all suggestive of ASMD, and if you see them, you might want to jump ahead and consider doing ASM activity right away. If somebody does not have those features, a child, but does just have hepatosplenomegaly, you would want to then consider ruling out other causes, including infection, malignancy and lymphoma, other types of lysosomal storage diseases, liver diseases, congestive heart failure, and hemolytic anemia. Once you rule those out, there's none of those, there's just hepatosplenomegaly, you would then want to consider, again, at that point, doing ASM enzyme activity. If you do the enzyme activity and it's low, you'd proceed directly to do SNPD1 gene sequencing. If the enzyme activity is equivocal, you'd want to repeat it first. And if it's still equivocal or low, then you'd again want to proceed to doing SNPD1 gene sequencing. There are several known genotype-phenotype correlations, and you can see them on the bottom of the screen. Infantile neurovisceral ASMD, there are a few specific genotypes and mutations that are associated with that, including R498L, L304P, and a frame shift at 333. And those are typical in the Ashkenazi population. For chronic visceral ASMD, there's also one mutation in particular, which is the Q294, as well as the W393G, which are more common in that chronic neurovisceral form. And then for people with chronic visceral or ASMD, type B or Niemann-Pick B, there are a few mutations there which seem to be neuroprotective, and the most common one is delta R610. If there are unknown or novel mutations which are fairly common, we do see that fairly frequently, then we need, unfortunately, just to kind of watch and see what's happening with the child and do clinical assessments to determine phenotype. Moving on to a diagnostic algorithm for ASMD presenting after childhood. If somebody has hepatosplenomegaly, we would want to look for different manifestations first because they don't tend to be presenting with acute neurologic phenotype like children might. So things that we would look at include a low HDL cholesterol, interstitial lung disease, and pathologic fractures. And those in combination with hepatosplenomegaly are highly suggestive of Niemann-Pick or ASMD, and you would want to proceed directly to enzymatic testing. If those are absent, then you would first want to rule out other causes, including infection, malignancy, lymphoma, other lysosomal diseases, liver disease, congestive heart failure, and hemolytic anemia. And if those are ruled out, then you would consider proceeding to doing ASM testing, measuring first ASM activity. If it's low, proceed directly to sequencing. If it's equivocal, repeat it. And again, if it's still equivocal or if it's low, then proceed to gene sequencing. And if there are variants found as well as a low enzyme activity, then that would be strongly suggestive of chronic visceral ASMD. Now I'll turn it back to Robin for a discussion about treatment.
Thank you, Melissa. So I'm now going to talk a little bit about the management of ASMD, both the management that we've had available in the past and at present, and advances that are currently being made in clinical trials that may change our management in the future. So as you've heard from Melissa, this is a complex multi-system disorder involving lots of different organ systems within the body. And up until now, we really haven't had any disease-modifying therapy, no way of affecting the underlying progression. And we've been left to manage the symptoms, to manage these patients symptomatically. And we've concentrated very much on the hypersplenism, on the pulmonary disease, on the lipid disease, and on the liver disease. And I'm going to start off by talking about how we've managed those traditionally. So as you've heard, most patients have significant hypersplenism and thrombocytopenia that can lead to bruising and bleeding. And these can be major clinical complications, life-threatening clinical complications. And these are handled as you might expect. When bleeding is life-threatening, patients are treated with blood products, platelets, clotting factors. If there are chronic problems with hypersplenism, then in the past people had considered and done splenectomies. And certainly if you do a splenectomy in these patients, their platelet counts will return to normal. You'll get rid of the bleeding problem, but unfortunately, it proved to be not very good for the rest of their disease. So you took the spleens out, and then the disease burden seemed to move from the spleen to the liver and the lungs, and you saw a huge increase in lipid storage in the liver and particularly the lungs. And these patients actually got much sicker because their lung disease and their liver disease got a lot worse. And so now we might consider partial splenectomy in cases where we really can't get on top of the bleeding, but we certainly wouldn't consider a total splenectomy in these patients anymore. So what about the pulmonary disease? This is an interstitial lung disease. These patients present like other patients with interstitial lung disease with type 1 respiratory failure. And the mainstay of treatment has been supplemental oxygen when it's required, domiciliary oxygen if available. Other measures have been tried, but mostly what we have in the literature are case reports or small series, and there really isn't any good evidence that things like steroids have a useful part to play. There's perhaps a bit more evidence on bronchopulmonary lavage in these patients. So they have a lipoid pneumonia, and the idea was that perhaps by bronchopulmonary lavage, you could wash all of that lipid material out of the alveoli and improve gas exchange, and this has been done in a few patients, and in some cases, some success has been reported. So this next slide is an example from a patient who was treated in the UK. And what you're seeing is two high-resolution CT images, one done before bronchopulmonary lavage and one done afterwards, showing that there is indeed an improvement in the radiological appearances, at least in the short term. And this patient did have better gas exchange in the short term. But there's no ongoing reports of these patients, and we really don't know whether these benefits are long-term, and my personal experience is that they're not, and that the disease recurs. Hyperlipidemia. So we know that these patients have an atherogenic lipid profile. We actually know from looking at mortality data that cardiovascular disease isn't a major cause of mortality in these patients. It's their liver disease and their lung disease that tends to be the major causes of mortality. But one can treat these patients with standard hypocholesterolemic agents to try and to optimize their total cholesterol and their lipid profiles. So those are all supportive measures, but they're not really going to modify the underlying disease. So what disease-modifying therapies do we have available? What can we actually do that will change the underlying progression? Well, actually, there have been potential disease-modifying therapies available for a number of years for this condition. And these came from looking at treatments that have been used for Gaucher disease. Both of these diseases are primarily diseases of macrophages. So it's the macrophages that store sphingomyelin in Niemann-Pick disease that infiltrate the liver and the spleen, the lungs and the bone marrow and cause the disease. And so there was a theory that perhaps by replacing the macrophages with donor macrophages, with macrophages from another individual which express the acid sphingomyelinase gene normally, you might be able to deal with the disease. So you might be able to treat this disease by hematopoietic stem cell transplantation. And this has been tried in the 90s and early 2000s in a number of patients. There are a number of different publications. And it did actually look quite promising, at least for the visceral disease. So after bone marrow transplantation, patients showed diminution in the size of the liver and the spleen. Their lung disease got better. So here again, we've got high resolution CT scans from a patient who had a stem cell transplant showing the CT before transplant and then 4 years after transplant. So long-term resolution of the lung disease in these patients by replacing their macrophages with donor macrophages that express the gene. Unfortunately, this approach wasn't particularly useful for the central nervous system disease. And so for the young patients in whom we were doing stem cell transplants in those days, it wasn't a very successful treatment. And it wasn't really considered at that time for older patients presenting with Niemann-Pick disease type B, because the morbidity and the mortality of the procedure itself was felt to outweigh any potential benefits. Now, as time has gone on, we've actually got much better at doing bone marrow transplantation. We do now offer it to adults with a number of malignant diseases and indeed some genetic diseases, and this might be something we could think of again in the future. Are there other ways that we could modify the disease progress in these patients? Well, this is a slide showing the causes of mortality in these patients and showing that the patients, for the most part, die from either respiratory disease or liver disease. And in those patients who are dying from liver disease, what they're dying from is hepatic cirrhosis. Fibrosis of the liver leads to hepatic cirrhosis. And for those patients who have cirrhosis who don't have a significant respiratory disease, then liver transplantation is actually an option for prolonging their life. You can deal with the cirrhosis with a liver transplantation. And a number of these patients do fulfill the criteria for liver transplantation, and liver transplantations have been done. Until recently, the evidence on this was just anecdotal. But last year, actually, the Chinese published a short case series of 7 pediatric patients who'd had liver transplants for acid sphingomyelinase deficiency. And in all of these patients, as you'd expect, the liver disease got better. The hematological disease gets better. The white cell counts and platelet counts improve because you've dealt with the cirrhosis and you've dealt with the portal hypertension. Although interestingly, you haven't dealt with the storage as such, so you would still expect to see storage in the spleen. So it's quite interesting that the white counts and the platelet counts get better. The lipid profile also gets better. So the lipid profile is due to disease in the liver. If you replace the liver, it's not surprising that the cholesterol gets better, the serum HDL goes up. But what perhaps is more surprising is that some of the other diseases in other organs get better as well. So the lung disease gets better. You can see here on the graphs, they've measured FEV1 and shown that that gets better after liver transplantation. If you look at the neurological development of these patients, then it certainly seems to stabilize and maybe even improve in some patients after liver transplantation. So what's going on here? Well, it seems that providing an organ, a liver, a donor liver in this case, that's providing a functional acid sphingomyelinase enzyme actually seems to be able to deal with disease not just in the liver, which you've replaced, but also in other organs as well. So this enzyme being produced in the liver must be able to find its way to other organs, perhaps via the macrophages, and actually help treat the disease there. And so perhaps what we're looking here is a sort of enzyme replacement therapy where you've using the donor liver as an enzyme factory. And so that takes us nicely on to the prospect of enzyme replacement therapy for acid sphingomyelinase deficiency. So we've now had enzyme replacement therapy for Gaucher disease for getting on for 30 years. And we know it's a highly effective treatment in Gaucher disease. And because of the biochemical and clinical similarities between Gaucher disease and acid sphingomyelinase deficiency, we'd really expect that enzyme replacement therapy might also be a very successful approach to this disease. Over the last 30 years, we've had enzyme replacement therapies come along for a number of other lysosomal storage disorders other than Gaucher disease, but we still don't have an enzyme replacement therapy commercially available for Niemann-Pick disease, Sphingomyelinase deficiency. And I'm going to spend the second part of this talk talking about that and how we're now making progress. So in enzyme replacement therapy, the idea is that you can synthesize the enzyme, the missing enzyme, outside the body, and then inject it back into the patient by infusing it into their blood. And from there, it will find its way to the cells where it needs to be. It will be taken up into those cells and targeted to the lysosome, where it can express its activity and complement the deficient activity in the disease, correct storage, and hopefully correct the disease. Ed Schuckman's group, after they cloned the gene, were very keen on examining the possibility of enzyme replacement therapy in Sphingomyelinase deficiency. They had a murine model, and it took them a certain amount of time, but back in 2000, they were actually publishing successful enzyme replacement therapy in a mouse with Niemann-Pick disease type B. So what you've got here is a series of micrographs of liver, lung, and spleen on the top from a normal mouse, in the middle from a mouse with Niemann-Pick disease type B. And you can see that in the middle, in the lung, the alveoli are full of lipid-laden cells, so the air spaces are gone because these animals also have a lipoid pneumonia. And in the liver and the spleen, you can see infiltration of fat-laden macrophages. And in these slides, that shows up as gaps because the fat disappears in processing. So what looks like vesicles in the liver and the spleen, actually the fat storage. And in the bottom panel, you have one of those Niemann-Pick disease type B mice that's been treated with enzyme replacement therapy. And you can see improvements in all three tissues. The liver and the spleen architecture are going back towards normal, and there's much more air spaces in the lungs. So you're getting rid of that lipoid pneumonia. And if you look at the graph on the other side of the slide, where we're looking at the mean percentage of sphingomyelin remaining following ERT, you can see that there are reductions in sphingomyelin content in the spleen, the liver, and the lung, but not in the brain. And this is true of all of the enzyme replacement therapies we have. Unfortunately, enzyme replacement therapy doesn't cross the blood-brain barrier, so you can't get active enzyme into the brain, so you can't reverse storage in the brain. And so this is potentially an effective treatment for the visceral manifestations of the disease, but unfortunately not for the neurological manifestations of the disease. So this was almost 20 years ago now, but we still don't have a commercially licensed treatment available. Now we know that commercial clinical development can take a long time, but it doesn't normally take that long. So what happened? What happened to make it last so long? Well, the problem was that although they could see good correction of the disease in the mice, they also ran into problems in the mouse model. The major problem was that when they dose escalated, so they gave the animals higher doses of recombinant human acid sphingomyelase, rhASM, those mice started to get unwell after their infusions. And it turned out that after an initial infusion of 20 milligrams per kilogram, the mice developed cardiogenic shock. Their blood pressure came down, they became very unwell, and some of them died. And a lot of work was done to try and find out what was happening here. Obviously, this put the clinical development program on hold for a while. And it turned out that what was happening is that when you gave these mice who had stored over their lifetime a large amount of sphingomyelin, if you gave them a big dose of the enzyme that broke it down, you suddenly released a lot of ceramide, which is the degradation product of sphingomyelin, into the circulation. Ceramide levels in the blood of the mice went up, and it turned out that this is cardiotoxic in mice and led to this cardiogenic shock. So with humans, as with mice, seeing this first dose ceramide release with higher doses of olipudase alpha, we do see a release of ceramide into the plasma of these patients, which could potentially lead to the same sort of problems we saw in the mice, although I'd have to say that fortunately, none of these patients in the phase 1A trial had significant clinical issues associated with this ceramide release. It did, however, cause an acute phase response. It was dose dependent. So here we've got some slides showing patients receiving different doses of enzyme, 0.3 mg per kg, 0.6 mg per kg, 1 mg per kg, and looking at various markers. In green, you've got that ceramide release I showed you in the last slide. In blue, you've got their CRP as a marker of the acute phase response, and in red, bilirubin as a potential marker of liver inflammation. And you can see that as the doses go up, as well as increased ceramide release, you get an increase in the acute phase response, with the CRP going up quite significantly in the patients on the higher doses, and a slight raise in the bilirubin as well, suggesting that there may be some liver inflammation. But as I said, none of these patients actually had clinical problems. This is a biochemical response, not a clinical response at this point. And this meant that they were able to go on and develop a phase 1b study. In the phase 1b study, which was now multiple dosing, looking at giving patients fortnightly infusions of acid sphingomyelinase for up to 26 weeks, they decided to use a dose escalation protocol in order to avoid that first dose effect of sphingomyelin going up. So the idea was that if you started patients off with a much lower dose of the enzyme for a number of infusions, and you can see the protocol on the bottom here, they had one infusion at 0.1, then two at 0.3, one at 0.6, one at 1. Then over those couple of month period, you would see a gradual breakdown of that initial load of sphingomyelin. And so the amount of ceramide being released into the circulation would be limited. So what you were aiming for was an effect somewhat similar to what we're doing at the moment with social isolation and coronavirus. We're aiming to flatten the curve. So instead of getting an enormous spike of ceramide after the first high dose infusion, by using lower doses, you keep those ceramide levels down over a longer period of time and avoid the acute phase response, avoid the possibility of any acute adverse events. So this was an open label study, 5 adult patients with non-neuronopathic acid sphingomyelinase deficiency were recruited. They went through this dose escalation and then had 26 weeks altogether, receiving up to 3 mg per kilogram. Those patients then transitioned into a long-term study where they continued to receive enzyme replacement therapy once every 2 weeks for up to 5 years. So a number of these patients have now been on treatment for really considerable amounts of time. And the primary objectives of the phase 1b study and the long-term study was the safety of this drug, but also looking at the efficacy of long-term administration of a drug that is called Olipudase Alfa, that is the recombinant acid sphingomyelinase in patients with acid sphingomyelinase deficiency. And we published this data a couple of years ago now. So again, only 5 patients, but the safety findings were very positive. It was well tolerated. There were really no serious adverse events. The transient adverse events we saw were what you'd expect in any clinical trial: headache, nausea, abdominal pain. The infusions were well tolerated as well. There really weren't any significant infusion-associated adverse events. And in fact, none of the patients developed significant titers of antibodies to Olipudase alpha either. So what about efficacy? Well, as part of this protocol, we took liver biopsies from our patients at baseline and at week 26. And so we were actually able to look at sphingomyelin storage in the liver. This was done microscopically. So they looked at stains. There are 2 different stains here that looks for sphingomyelin. And you can see in the micrographs an obvious improvement in this patient in the lipid storage baseline compared to week 26. And we could quantitate this by trying to work out the tissue area occupied by sphingomyelin in those sections. And you can see for each of the 5 patients that although the amount of sphingomyelin storage in the liver seen at baseline was variable in all the patients where we were able to get a follow-up specimen, one of the patients didn't have his 6-month liver biopsy, there was a marked and significant improvement in the amount of sphingomyelin being seen in the liver. We measured ceramide levels in the blood. We were trying to avoid that acute spike of ceramide after the first infusion. And by using that dose escalation protocol I talked about, we did that very effectively. And you can see that actually there was very little rise in ceramide at all from baseline. And then there was a gradual decrease over the whole 6-month period. So we convinced ourselves that we were able to avoid any ceramide-related toxicity using this procedure and bring the ceramide levels down to flatten the curve. And what about the visceral involvement? Well, we saw remarkable improvements in visceral involvement. So all of the patients had improvements in liver and spleen volume shown at the top here. Again, these patients had very different sized livers and spleens at baseline. What you're showing is the multiples of normal of the liver volume and the spleen volume, but they all came down. The lung disease also improves. So 3 of the patients, as you can see here, had clinically significant lung disease at baseline. And in all of those, the DLCO improved significantly with treatment. And when we looked at the high-resolution CT chests and we scored the involvement with the ground glass involvement, the interstitial lung disease, the reticulonodular reticular nodulus shadowing, you can again see that compared to baseline at 6 months, 18 months, and 30 months in the prolonged study, there were ongoing improvements in lung disease, which was very encouraging. And here's just some examples of high-resolution CT from one patient at baseline, 26 weeks and 78 weeks, showing improvements in the lung findings. And if you look where the arrows are, particularly the white arrow, I think shows an area where you can see quite obvious improvement in the appearances over time. We did some other things as well. So we looked at blood tests and the lipid profiles. The liver function tests improved in all the patients. Improvements in bone mineral density in the spine were observed in some of the patients. Going out to 30 months, again, the adverse events were mostly mild, all mild, and included headache, nausea, and abdominal pain, the sort of things you'd expect. So no real treatment-specific adverse events, and no patients developed anti-drug antibodies, which was good as well. So really this, although it's only 5 patients, is a remarkable study because it shows improvements in all the patients in all the relevant clinical and biochemical parameters. And at the same time, we've avoided any of that toxicity we saw in the initial mouse studies that actually delayed this clinical development program. And the encouraging results of this phase 1 study then led to a much larger randomized double-blind placebo-controlled phase 2/3 study. So the pivotal study is done in adults. So these patients are over 18 years. They have Niemann-Pick disease type B, so they have chronic visceral Sphingomyelinase deficiency. And we recruited 36 patients, and they were randomized to receive either Olipudase Alfa. They went through the same dose escalation protocol to receive a final dose of 3 mg per kilogram every 2 weeks for a year. And another group of patients who went through a placebo dose escalation and then received placebo for a year. And the primary outcomes were changes in spleen volume and the change in infiltrative lung disease after a year of treatment. At the same time, they also did a pediatric study called ASCEND-Peds, which was open label, looking at under 18-year-old patients. They had 20 patients. They also went through dose escalation, but all ended up receiving 3 mg per kilogram every 2 weeks, up to 64 weeks. And the primary outcomes for that were a little different. They were looking at safety, clinically significant changes in laboratory parameters, and clinically significant changes in physical examination. Now, there's no publications from this study yet, but all the patients in ASCEND have now completed the 1 year of treatment. The database was locked last year, and earlier this year, Sanofi Genzyme were able to release as a press release preliminary results, and these were really very positive. This was released back in January. And what they showed in looking at the infiltrative lung disease is that there was an improvement in DLCO from baseline to 52 of 22% in the treatment arm, compared with only 3% for the placebo arm, a 19% difference that was highly statistically significant. The other main endpoint was spleen volume, and this was reduced by almost 40% in the treatment arm, compared with really staying very stable in the placebo arm. And again, highly significantly significant. So highly significant improvements in both of the main primary outcomes. So what about the results of the pediatric study? Well, the pediatric study had very similar results. After a year of treatment, the DLCO increased by a mean of 33%. There were only 9 patients who were actually able to do the test at baseline, but in those we saw a 33% increase. And the spleen volumes decreased by almost 50%. With individual patients ranging from 23 to 61%. Both of these studies really had very positive results. Patients showed highly significant improvements in all of the major manifestations of the disease. And going forward, it seems that Olipudase alpha really has the potential not just to stabilize disease or to slow progression, but to reverse the disease and to restore organ function back to normal. And hopefully going forward, these patients will have the potential to lead normal lives with this treatment being available, we would hope. Okay, so for the last part, we're going to take this back into the real world and have a couple of case presentations, a pediatric presentation and an adult presentation, to try and illustrate some of the points we've made about clinical presentation, about diagnosis, and about treatment, and perhaps about what the availability of enzyme replacement therapy will mean for these patients going forward. So Melissa's going to start with a pediatric case, and then I'll follow up with an adult case afterwards. Melissa.
Thanks, Robin. Now we're going to share some real-world examples to illustrate the kind of health challenges that people with chronic visceral ASMD often face, and discuss the diagnostic and management approaches that we used. So I'm going to be discussing a male adolescent with chronic visceral ASMD, focusing particularly on the growth restriction. So this was a young man who presented with hepatosplenomegaly at age 18 months. He was eventually referred to a geneticist about 3 months later at 21 months, and the differential diagnosis at that point included Gaucher disease versus acid sphingomyelinase deficiency. And dual testing was sent, which is what we often like to do and strongly encourage doing, because the disorders can look so similar at the beginning. The labs that test for one typically test for the other, and you can save a lot of time and effort by doing dual testing. So dual testing was sent and did confirm the diagnosis of ASMD. Because the ASM activity was within the affected range, and he had a genotype that was consistent with ASMD. He had a combination of the common Niemann-Pick B or delta R610 neuroprotective mutation, along with one of the type A, that frameshift mutation. And because he had the delta R610 mutation, we knew that it would be neuroprotective and he would have type B, likely a more severe form because of that combination with the type A. So the relevant review of systems. This young man had a history of bronchitis at least twice. He had multiple ear infections resulting in bilateral myringotomy tube placement. He also had intermittent abdominal pain, including frequent diarrhea, with extensive evaluations and studies with no obvious etiology found, so it was eventually attributed to ASMD. And hematologically, he had frequent nosebleeds, approximately at 1.10 per year, often lasting about 15 minutes. But remarkably, he never required cauterization, packing, or emergency department visits, although many patients do require those visits because the nosebleeds can be so severe because of the hematologic issues. And he also had easy bruising. And in terms of his musculoskeletal system, he had intermittent pain in shoulders, knees, and joints, but he had no broken bones. So between ages 2 and 18, he had normal intellectual development, and he was developmentally appropriate for age. But for the past decade, starting from about 8 or 10 years of age, he was very concerned about his size. So his physical exam, he was small, appearing younger than his stated age. His lungs, importantly, were clear. But he had massive hepatosplenomegaly, and you can see a cut from his MRI on the slide. In the liver edge was about 1 centimeter above the level of the umbilicus, and the spleen actually extended almost into his pelvis, and it was about 3 centimeters below the level of the umbilicus. Again, this is consistent with pretty severe systemic manifestations of Niemann-Pick B, which is consistent with the genotype. His chronological age at 14 years and 2 months correlated with Ehrlich-Pyle bone age of 11 years. So the bone age delay was 38 months, and the standard deviation was 10 months. So this is pretty significant bone age delay, which is consistent with the overall growth delay. And you can see here his growth chart, that this is his height, and you can see it lingering around the 2nd percentile, and then it dips significantly during his early adolescent years. When he was 14 years old, he was the average height for about a boy of 10 years of age. So it was significant and psychosocially challenging for a kid in middle school to have a growth delay that's that significant. Because of that significant delay, we actually referred him to an endocrinologist who did start growth hormone injections at that time, which you can see did result in significant growth, to the point where by age about 17, 18, he was back on the curve. And his weight corresponded to the height, and you can see that same pattern. When the growth hormone injection started, and he had a significant improvement and cross percentiles for weight. The rationale for growth hormone use in this child was that his IGF-1 was low, was 97, and for his age, it should have been over 192. The IGF binding protein 3 was also the low end of normal. And because he had this deficient growth hormone peak response to clonidine and arginine during a growth hormone stimulation test, it was determined that by the endocrinologist that this particular child would be appropriate for growth hormone therapy. And then also another feature was that during the early stages of puberty, when his growth velocity should have been accelerating, it was progressively slower. So all of those features were the rationale for growth hormone use in this particular young man. It doesn't mean that every person with Niemann-Pick needs growth hormone. In fact, many who are small do have these assessments by endocrinology and don't fulfill these criteria and don't ultimately qualify for growth hormone. But for this kid, it was actually nice that we can find these justifications for using it. So in summary, I presented a male adolescent with chronic visceral ASMD on currently available standard disease management, which included watching weighting, encouraging nutrition, and in his case, he was able to get growth hormone. The predominant phenotypic characteristics included lung disease, hepatosplenomegaly, frequent nosebleeds, frequent abdominal pain and diarrhea, and growth restriction with an adolescent Z-score for height below 3, significant lag in bone age, delayed onset of pubertal growth spurt, and then he eventually did likely have his growth spurt because of this therapeutic growth hormone injections. Now I will pass it back to Robin so he can tell you about one of his patients.
Okay, thank you, Melissa. So I'm going to present the case of a 48-year-old woman with acid Sphingomyelinase deficiency. And we'll start with the referral letter I got. I got this, I think, towards the beginning of 2019. This was a letter from her GP saying, thank you very much for seeing this lady who we know has Niemann-Pick disease. But she'd just been admitted to hospital with a major GI hemorrhage and dropped her hemoglobin right down to 70. She was transfused at that time. She had a lot of investigations, and an endoscopy showed that she looked like she had portal hypertension. She had varices, and although they didn't see a bleeding point, they assumed this was due to a variceal bleed. So she was discharged with a diagnosis of alcoholic liver disease, but she didn't really think that was quite right because she didn't drink very much alcohol, and she thought Niemann-Pick disease did cause liver disease. So she went to see her GP and said, could she please be referred to a specialist? And so they asked us to see her. And so, as I said, she's a 48-year-old nurse, actually a respiratory nurse, and she'd had her Niemann-Pick disease diagnosed in childhood, much like Dr. Wasserstein's patient. So she presented early on in life with a distended abdomen, failure to thrive, and eventually was seen, I think, by the liver doctors and had a liver biopsy done at the age of 4, and the diagnosis of acid Sphingomyelinase deficiency was made. There was no specific treatment at that time. She'd been seen by a liver team, not an inherited metabolic disease team, so she was referred back to her local pediatricians. She did actually do quite well in childhood. She had catch-up growth, went through puberty as normal at the age of 16, and at that point was discharged from pediatric care and didn't actually have any ongoing adult follow-up at all. She was noted to have hypercholesterolemia when she was in her 20s. She, at that point, was referred back to the liver unit, but they assessed her and didn't think she had any evidence of liver fibrosis at that stage and discharged her again. And she was then basically well from a Niemann-Pick point of view until about 3 years prior to this presentation, when she had a large pervaginal bleed. Now, following that, and no cause for it was ever found, she had persistent anemia and thrombocytopenia with the early bruising, nosebleeds, and she was referred to the hematology department, and they put this down to hypersplenism. And then, as we've said, she had this major GI bleed with hematemesis, red blood PR, and was shown at that point to have varices and obvious portal hypertension. There was one other significant part of the past medical history, which we'll come back to later, was that she had a single episode of fast atrial fibrillation 2 years prior to this presentation. When I saw her, she was on a proton pump inhibitor, she was on a beta blocker because of the portal hypertension, she was on a number of nutritional supplements. In the family history, she only has one sister who's unaffected as far as we know, certainly doesn't have any clinical problems, and she has no children of her own. Directly questioning her, she had been complaining for a few months of increasing shortness of breath on exertion, finding it increasingly difficult to go upstairs, to exercise out of doors for any prolonged period of time. And also at the end of a long day on her feet, she did notice ankle edema from time to time. On examination, she was still jaundiced. She had stigmata of chronic liver disease with spider nevi. She had a moderate hepatomegaly and a massive splenomegaly with the spleen coming right down across into the right iliac fossa. But there wasn't any ascites. And listening to her lungs, she had fine bibasal crepitations suggestive of interstitial lung disease. Here are our initial lab results. Interestingly, she didn't have hypercholesterolemia, but she did have the very low HDL that's characteristic of acid sphingomyelinase deficiency. She was, as we said, jaundiced with a high bilirubin. Her liver function tests weren't normal, and her platelet count was very low, as you'd expect with a large spleen, although her white cell count was actually in the normal range. And she had a moderately elevated chitotriosidase. So you see very large elevations of chitotriosidase in Gaucher disease, but in Niemann-Pick disease, this is pretty typical for the levels we see. We did pulmonary function tests. Actually, her spirometry was pretty normal, as you'd expect, but her gas exchange was awful. So she had a KCO, a transfer factor of only 35%. On exercising, as she desaturated to 82% on room air. And a bubble echocardiogram actually showed that she had pulmonary hypertension with pulmonary arteriovenous shunting. And this is probably, I would have thought, what caused that episode of fast AF she had a number of years ago. And probably incipient right heart failure secondary to the pulmonary hypertension is what's causing the ankle edema she's getting. We did some imaging. So here you've got some MRI images of the abdomen here showing the enormous spleen. And within the spleen, multiple splenic nodules, which again is pretty typical of acid sphingomyelinase deficiency. Here on a transverse section, you can see that the liver is also grossly enlarged, and you can see the stomach there being trapped between the liver and the spleen. And so for a lot of these patients, one of the clinical problems they get is that they lose weight, they have a very poor appetite, early satiety, and that's because the stomach simply can't expand. So if you have any food at all, that stomach can't expand, you feel full very quickly, and you don't eat very much. Here's a high-resolution CT of the chest showing the characteristic findings with crazy paving pattern, the enlarged pulmonary artery going with her pulmonary hypertension, some coronary artery calcification as well, suggesting that may be some incipient cardiovascular disease there too. Here's further down in the chest, showing really a lot of ground glass appearance, a lot of interstitial lung disease. And interestingly, on her HRCT, they also commented on these paravertebral soft tissue lesions, which are an interesting feature and which the radiologist thought might represent foci of extramedullary hematopoiesis. So suggesting that actually there's significant Niemann-Pick involvement of the bone marrow and that hematopoiesis is being moved out into soft tissues. We haven't biopsied them, so I'm not exactly sure what they really represent. Okay, so we have a 48-year-old woman with acid sphingomyelinase deficiency who has established cirrhosis and decompensated liver disease. So what management options do we have available for this woman? Well, actually, the management here is the same as it is for end-stage liver cirrhosis in any other patient. The management we have available to us is liver transplant. And so we referred her to our local transplant team for consideration of orthotopic liver transplant. And I went along to the transplant multidisciplinary team meeting to discuss her. There was no doubt that she met the criteria for listing for transplant. She had cirrhosis with portal hypertension and a hepatopulmonary syndrome, and they thought that this, at least in part, was contributing to the pulmonary hypertension, although I think the interstitial lung disease due to the acid sphingomyelinase deficiency was also important. So she certainly met the criteria. There were, however, a number of concerns about whether she was fit for the procedure or not, and her respiratory status was the real concern here. We know she desaturates on exercise, and there was a question about whether, if she went onto a ventilator after a liver transplant, she'd expect to spend a few days on ITU being ventilated. Would we ever get her off it again? Would we be able to wean her off the ventilator? And also there was a concern to what extent her interstitial lung disease was progressive. If we gave her a liver transplant and dealt with the liver disease, would she then succumb to progressive lung disease? We know that at least a quarter of the patients with Niemann-Pick disease, it's their lung disease that kills them. Or would this lung disease be reversible? And there, having that data I showed you earlier from that a series of Chinese patients who'd had a liver transplant and had improvements in their lung disease. That allowed us to make the case that we would be optimistic that actually after liver transplant, we might see some improvements in her lung disease. There were some other technical issues. She had a splenic artery aneurysm. They were quite keen on removing the spleen during the procedure for the liver transplant. We still weren't very keen on that. As I've said, we really don't like taking the spleens out of patients with ASMD because it leads to a marked deterioration in their condition as far as their lung disease goes. If you were giving them a new liver at the same time, would you get over that? Well, we simply don't have any evidence for that. And erring on the side of caution, we thought we'd rather leave the spleen in situ, and eventually the surgeons were happy to do that. The surgeons did say, is there anything else we can try? Can we give her enzyme replacement therapy rather than having to do this transplant, or would that improve her condition beforehand? And the answer is actually, if it was available, it almost certainly would, because we could give her enzyme replacement therapy for 6 months or 12 months. And as the data I've shown you from the ASCEND trial suggests, we'd expect to see a very significant improvement in her lung function over that period, which would make her a much better candidate for this sort of big surgery. We did try and get hold of enzyme replacement therapy on a compassionate use basis for this patient, but unfortunately at that point, there was only just enough enzyme available for the patients in the trial, and it wasn't available for anybody being treated outside of a trial condition. So yes, actually having enzyme replacement therapy in this sort of situation would help. It would allow you to optimize the condition of your patient. You wouldn't be able to reverse the cirrhosis. There's no way you can reverse fibrosis once it's there, but you would probably have made her a much better surgical candidate. Fortunately, however, they did agree to list her, and I'm pleased to say that she actually had her liver transplant done last December. And the last time I saw her, which was a couple of months ago, she was doing very well. She was doing well from the transplant point of view. When she was initially discharged from hospital, she had actually required supplemental domiciliary oxygen at home, but she was coming off that. And it did seem that her lung function was actually improving. And we're optimistic that going forward, she's going to do very well. And hopefully, if there is enzyme replacement therapy available commercially in the future, then if we can add that into her treatment, we should really be able to optimize her condition and to reverse some of the lung disease if it hasn't already been reversed by the liver transplantation at that stage. Okay, so to wrap up, we've talked to you today about Sphingomyelinase deficiency. We've given you some of the history. We've gone over the clinical presentation, the diagnosis, and the management. This is a disease that's associated with significant morbidity and mortality, but there are interventions that can improve the quality of life of patients, symptomatic interventions. And going forward, we now have emerging data from clinical trials that we're actually going to have very effective disease-modifying therapy that will be able to transform the lives of these patients going forward and even reverse this condition and hopefully allow them to live very normal lives in the future, providing they're diagnosed and treated at a sufficiently early stage in their disease. I hope you've enjoyed the presentations today. I hope you found it educational and informative. And I hope you'll find it useful for your practice now and going forward into the future. And Melissa and I would both like to thank you for coming and for your attention.
Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/NPH860. This activity is supported by an educational grant from Sanofi Genzyme. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.